Hi everyone, good afternoon and welcome to today's Facebook Live session. Today we're going to talk about obesity and the topic is let's talk about obesity. So, two other doctors. So I am Dr. Ghaffur and I am a general and bariatric surgeon at Island Hospital. And together with me is Dr. Malik, who is an endocrinologist, and as well as Dr. Badrul, who is also a surgeon at Island Hospital. So, obesity is a big problem in Malaysia. As you all are well aware, almost 48% of our population is overweight. And from that number, we find that almost 18% are predominantly people with other comorbids and other problems. So it is a big issue with regards to healthcare and healthcare financing and managing patients with this problem. So today we are going to discuss what are the options you have if you are obese or overweight, and what are the options that we can offer you at Island Hospital as well. And we will have an expert panel with me today, and I hope that we can provide relevant information and you can ask whatever you want on this platform and we'll be glad to answer your questions. So before we carry on, I think I will allow our panel to introduce themselves. I think Dr. Malik, maybe you can say a few words.
Yeah, hello. I'm an endocrinologist in Island Hospital. I primarily treat diabetes and other hormonal problems. I'm also a general physician. And my colleague here, Badru, will introduce himself.
Dr. Badrul.
Hi, I'm Dr. Badri. I'm the adult and pediatric surgeon in Island Hospital. I do a lot of laparoscopy, and indirectly because of that, then we handle a lot of bariatric as well. It's become a bit of a special interest topic for me as well.
Great. Okay, so I think this will be a session that is based on some slides, and also we'll make it as informal as possible so that you can ask in, and we'll be more than happy to entertain any questions that you might have. So let's put up some slides first and let's discuss them before we proceed on. Okay, so these are the list of speakers today. And okay, so when you talk about obesity, you talk about BMI, so body mass index. So BMI is actually the easiest, and it is a universal language for all of us to actually to relay to other physicians whether or not a patient is overweight, or patient is obese, or patient is severely obese. So a normal weighted person will have a BMI of 18.5 to about 24.9. An overweight patient will have 25 to 29.9, and anything beyond that is obese. However, this criteria has been there for a long time, and it might differ from patient to patient and also population to population. So I think I'll kickstart by asking Dr. Malik. Dr. Malik, what do you think are the issues regarding this BMI when actually we have a different range to classify BMI in patients that have got from different populations, I mean.
Okay.
From patients who are from Western populations and patients who are from Asian populations.
Okay, so BMI generally is useful for someone who's average. If you do a lot of exercise, you're doing a lot of bodybuilding, weightlifting and all that, then BMI doesn't really work. Now, BMI cutoff for Asians is actually much lower. So a low-risk patient would be up to a BMI of 22.9, moderate risk 23 to 27.5, and high risk, which means that you are obese, would be 27.5 kilograms per meter squared. A lot of apps can calculate this for you. So you can actually go online, you can download anything. There are plenty of apps which you can use. And the reason for this is primarily based on the fact that if you are Asian, especially South Asian, the BMIs that are accepted and the waist circumferences that are accepted are much lower, because when we talk about obesity, we talk about complications of disease and onset of diabetes, heart disease, and so on. And in South Asians, this occurs at a much lower sort of BMI and a much lower waist circumference because of the fat that is deposited inside. So because of this visceral fat is more toxic, makes someone more prone to develop these illnesses. So the cutoff values for South Asians, Chinese, for blacks, and for Caucasians, white population is very different. So on average, we take 80 centimeters, 80 cm for women, and about 90 cm for men as our threshold. Now, the reason there's a shift in Malaysia as well as elsewhere, is that things have changed. So, you walk into McDonald's, you can buy mega cups, you can buy a huge triple Big Mac, which you never were able to buy before. Nasi lemak sizes have changed, diet has changed. You can get, 2,000 calories at 2 o'clock in the morning quite easily. So this has actually contributed to the obesity epidemic. And if you look at Malaysia, 44.2% of the population actually has obesity or overweight. And because of this, Malaysia is considered to be one of the fattest countries in the region. And this is quite scary, actually. Now, when we talk about weight loss, we talk about making it beneficial. It's not so that you can fit into your bikini or things like that. It's actually about being medically beneficial. So to prevent diabetes, in someone who has a risk factor, you need to lose about 3 to 10%. To cure your diabetes, that means go into remission, you need to lose about 10 to 15%. Maximal, maybe beyond 15%. Cure hypertension, cure dyslipidemia, the figures are in front of you. But generally speaking, you need to lose about 15% of your body weight to see significant benefit. Again, stress incontinence, reflux, polycystic ovaries, all these are conditions that we commonly see in the clinic. And to get rid of all of this, you need to lose in excess of 15% of body weight before you can actually see benefit. So remission, cure of diabetes is actually very possible. And, while we use medications, you can see that with lifestyle, if I ask someone to go and diet and exercise, you can lose about 3 to 5%. If I put them on a very low calorie diet for a month or 2 or 3 weeks, they may lose 10%, but the rate of regain is very high. If I put someone on medications, for example, and a lot of these medications that we use nowadays are diabetes-related drugs, which can be used in normal individuals as well, you can lose up to 10%. Gastric surgery, bypass surgery, and all the other things that bariatric surgery actually allow you to lose more than 15%. And this is where the action happens. With 10% or less weight loss, you don't see cure of diabetes, you don't see hypertension being cured. But when you lose more than 10 to 15%, then there is a real possibility that you may reverse some of the illnesses that you have. And this is a very exciting prospect. And this is what some of these colleagues here of mine will talk about. So bariatric surgery is a serious option in patients who have diabetes, as well as in non-diabetics, because what we're trying to do is, even if I can cure your diabetes for 10 years, it means that I've reduced your risk of developing complications by 10 years. If you're non-diabetic, it means that I can prevent it from happening. It means that I can slow down the onset of your heart disease and so on. So bariatric surgery for someone who is obese is actually a real option. And it is associated with progressive weight loss, which can be sustained. And also, importantly, in the Stampede study, which was the gold standard study, which we all refer to, there was a significant reduction of HbA1c, which is the gold standard. So it means that a medical or a surgical procedure now can actually cure your diabetes. In addition to whatever else, lifestyle changes and all, we should actually consider bariatric surgery as a means of treating diabetes. So that's what bariatric surgery that's how bariatric surgery would play a role in my practice. And I would offer it to patients who have diabetes or who are overweight, who would, in addition to maybe taking tablets, may require injections and so on, and diet and exercise. And these patients, if they're highly motivated, would be a candidate for bariatric surgery.
Okay, thanks, Dr. Malik. So let's talk about bariatric surgery. So though the term sounds very, surgery, everybody hears surgery and they go, oh, it's operation, pembedahan, you have to open up someone and all. But most of these procedures are done with very minimal access. So in Island Hospital, we have a few procedures that we can offer, and these are the ones that we do quite commonly. In fact, we have another one as well, but these are the three most predominant one. I think I will let Dr. Badrul talk a bit on sleeve gastrectomy. And I think we just, on sleeve gastrectomy, as Dr. Badrul has done a fair number, and I believe that his experience is very valuable in this. So, Dr. Badrul, what do you think about sleeve gastrectomy?
Well, when we started doing bariatric surgery, of course, the gold standard was with the gastric bypass, the rule gastric bypass. But then you get into this group of patients who are very, very obese. And then you need an operation that is either better than the gastric bypass, or you need an operation that is, we need to stage the operation, meaning you do something which is not as complicated as a gastric bypass, but it helps to bring the weight down a bit before you do another operation to get the weight down to minimum. So that's how sleeve gastrectomy came about. It was initially part of another procedure which is very complex. And so whenever we talk, I'm sure Gafur will agree with this, whenever as surgeons we always follow the KISS principle. Keep it simple and straightforward. So we make the operation simple. So this is how this has sleeve gastrectomy, or we call it the gastric sleeve. It's become the most popular bariatric operation now because it's quite straightforward. And again, as surgeons, if you do the same thing again and again, you make the operation simple and you make the operation very, very safe. And as we do more and more of this procedure, you find that this procedure is very good. It's actually comparable to the gold standard, the so-called gold standard, which is the gastric bypass. So it has become the most popular bariatric operation the world over. Even in America, more and more people, America was where gastric bypass was done a lot. But now even sleeve has taken over bypass in America. So the sleeve has become very popular, and you know, as more and more of us are doing it, we find that it's actually just as effective as the bypass and not so complex. And when it's not so complex, then the complications are less. Of course, as Dr. Gafur mentioned, there are other operations that have been, you know, you always try and find ways to make things better. And there's actually another operation which is between the sleeve and the bypass, which is also very, very good. And sometimes we reserve this more complex operation for people with very bad diabetes control. So we do that.
So thanks, Dr. Badrul. So I believe Dr. Badrul, I mean, I agree with you. I think sleeve is the most common operation in the world for weight loss. And I think when many of us began doing this operation, you know, a few years ago, even 8, 9 years, 6, 7 years ago, we never knew that this operation could stand the test of time, you know, because newer procedures were coming into play. But basically, Dr. Badrul, maybe you can explain as well what do you actually do when you do a sleeve gastrectomy actually?
I've actually prepared a little video at the end.
Okay, great.
So we can
see a video
at the end, you know, just to
all right. Okay, that's good. So we have
show the gory bits.
Okay, so we have other procedures as well. So sleeve is, in my opinion, very good for patients who are aiming for weight loss. But if patients come in with a severe metabolic syndrome, so this is problems associated with obesity. For example, if patients who are obese or overweight, they normally don't only come because their weight is in excess, but normally they come and their primary gateway is through someone like Dr. Malik, and then Dr. Malik will pass the toll first, then they will come to us, and normally they will come with other problems such as diabetes and hypertension. So when these problems are quite extensive, then they might require something. If we say, orang kita kata benda yang lebih kuat lah daripada sleeve gastrectomy, we have one step higher, then we go for gastric bypass. So the most common gastric bypass in Asia or South Asia is not actually the Ruwai, it's actually the one anastomosis gastric bypass. In short, in summary, sleeve is untuk to make the stomach pouch small. That's it. But a gastric bypass, you make the stomach pouch small and you make your intestine length also shorter by doing a bypass. So by doing that, there's a lot of other benefits that this operation may confer. But Dr. Bol, I think you must agree with Dr. Badrul that sleeve alone is not only to reduce the pouch. That means sleeve alone is not only to reduce consumption. There are other benefits that are there in the sleeve as well.
Right.
And what benefits do you think there are?
Well, the reason why I'm sure you agree with this as well. You're in favor of doing sleeve is because as a oncology surgeon, whenever we do this, in this part of our world, we do get quite a high number of gastric cancers. When we do a sleeve, we remove about 70 to 80% of the stomach without causing too much complication. So that's one way, that portion of the stomach that we remove, you actually remove that part of the stomach. So you reduce the risk to a certain extent of gastric cancer. And for the same reason, I'm not too keen on the gastric bypass because once we do the bypass, there's no way for us to survey that remaining gastric pouch. So it worries me a little bit. It makes it difficult for us to see whether something is going on in that bit of stomach that we left behind. And for the local population, for people in Penang, for instance, we like our food. And I tell my patients, after I do a sleeve for them, they don't actually need to change their diet, unlike the bypass. The amount is less, yes, of course, a third down by 2/3, but what you eat is essentially the same. So, and that is, that makes it a bit more easy to digest, although it is an operation.
Yeah. Thank you, Mr. Badrul. So the other aspect that I think is very important is why all this dieting and all these measures all fail is because there is very little implication to the hormonal aspect of the body when you want to diet or when you want to exercise or things like that. But when you do a sleeve gastrectomy, you remove a portion of the stomach known as the fundus. And the fundus of the stomach actually secretes this hormone as ghrelin. And ghrelin has got a very strong action on our satiety, yang kita rasa kenyang, yang kita rasa lapar. So if it secretes it out, then that is the reason why we tend to go and binge, buka peti ais, and take food and things like that. So these are all the factors why sleeve is, a very popular and very, very affable procedure to offer to patients on both sides. So I think I'll talk a bit on gastric balloon. So a gastric balloon is the new kid on the block. So gastric balloon is a new kid on the block in the sense that we have got new technologies in balloon currently. So when I began doing balloons a few years ago, most of the balloons have to be inserted into the patient by endoscopy. That means we take the patient into endoscopy, put in a scope into their mouth, put in the balloon, and the balloon stays there. And then after 6 months or 1 year, we remove the balloon. During that time, the balloon fills up with water, it occupies space, and so the patient doesn't eat so much and they lose weight. Now we have got newer balloons. Newer balloons which we have now are the ones that don't require endoscopy, don't require insertion by scope, and don't require removal also by scope. So they are swallowable. We can just swallow the balloon, and then we can expand the balloon with water, and then subsequently 4 months later, the valve in the balloon will degrade, the water will come out, and the balloon will come out normally melalui cara berak je and the patient is okay. So these are new things that actually are very attractive, and many patients that don't have very high BMI, they actually are in favor of these type of balloons So you don't have to be really big, to want or need our treatment. You can be someone who actually just wants to lose weight, and we will be able to offer various types of treatments that we have. So I think I will ask Dr. Malik this. Dr. Malik, can you grow old and live a long life even with the reduced stomach size?
Yes, definitely, because eventually if you go for bypass surgery, there is a chance that the pouch will regrow anyway. But you have to be careful. That's why it's always important to control your diet even after a sleeve gastrectomy. It doesn't mean that just because you've had a gastrectomy or have a balloon in, you can eat whatever you want liberally. Portions have to be limited. Otherwise, the risk of pouch regrowth is quite high, or re-expansion. So yes, you can live. In fact, you may more likely to live to an old age.
Yeah, you probably live longer.
You can live longer.
Correct. You live longer.
So there are various studies that show that, you know, if you do bariatric surgery, you can actually increase patients' life latency, and also you reduce their chance of getting cancers.
Correct.
Mhm.
Correct.
You know, so the benefit goes way beyond just weight loss, lah.
Correct.
So what are the type of food you cannot eat, boss, if you have this kind of, if you make your stomach small?
Basically, I think, it depends on what period it is from the time you have your surgery. For the first month or so, you may well be on a liquid diet to a soft diet. And then eventually, we always tell patients, look, avoid spicy foods. It's all about the volume of food that you eat. So then it becomes quality rather than quantity. You're not eating for the sake of finishing 3 plates of rice. It's about tasting that one portion of rice that gives you satisfaction, and you hope that with you get satisfied more easily. So a small portion of food will satisfy your craving. Like anything, if you force it, it will go in. But you really need to be careful. So it's more about choosing the quality rather than quantity once you have one of these procedures done.
Badul, I've got patients who have told me that once they do the sleeve, Malay patient, they rasa macam kat syurga, they got no appetite. They don't feel hungry,
Yeah.
Do you have similar experiences?
Yeah.
So it's something very...
It removes that obsession with
Right.
food.
Correct.
It removes that completely because they don't feel hungry.
Yeah.
But at the same time, they don't feel tired.
Yeah, they don't feel
You
tired.
don't feel like you are listless
yeah.
and lack of energy.
I mean, you always say Malaysians, the first thing you do is, first question you ask is, oh, sudah makan? That's your greeting.
Yeah, correct.
Chapala boy.
Boy.
So all this really I think it's just our mind revolves around food most of the time.
Yeah. But actually, Dr. Malik, you have to agree, being number one as the most obese nation in Southeast Asia is not a title that we should
Be proud of.
Correct. We should, and we need some drastic measures. That's why this talk is there, and we hope that everyone can get some benefit from it. So we have a question from the audience, from one of our. Will the secretion of GLP-1 increase? Dr. Malik?
Yes, and
Okay.
that's from Aspal. Okay, I know who you are.
Okay.
Okay, so yes, there will be an increase.
Okay.
GLP-1 basically is a hormone that controls the appetite to
Okay.
a certain extent.
Okay.
So there are injectable.
Does it increase or reduce appetite, Dr. Malik?
It decreases.
Decreases. Correct.
Decreases the appetite.
GLP-1. Okay.
So GLP-1 works at the stomach, makes you feel full. It works in your mind as well, in the brain.
Correct.
And that also controls the food. So we do give this as a medication for weight loss.
Okay.
But generally, this happens naturally after bariatric surgery.
Yeah. Dr. Malik, is it true that the medication for GLP-1 originated from the saliva of
The Gila monster.
Of the what monster?
Gila monster.
Gila monster, which is a biawak.
Biawak lah.
Biawak.
Biawaks don't eat much.
Biawaks don't, exactly.
So biawaks don't eat much. GLP-1 allows you to feel full all the time.
Yeah.
So this was in Arizona. It started off, but we've come a long way from that lah. We've got analogs now. There are a few in the market.
Right.
And these now allow us to actually treat patients who are diabetic and non-diabetic either to help them lose weight,
Right.
or even to prepare them for surgery, so make the life of the surgeon a bit easier.
Right. So do you think that which group of patients would benefit actually from this medication alone?
You see, it's always the 10% threshold that we talk about.
Right.
To get anything that's beneficial metabolically, you have to cross 10 to 15%. Then you see remission of diabetes, you see hypertension, cholesterol, everything going down. And medication-wise, we never go beyond 10%. It's very difficult.
Yeah.
It's very unusual.
Yeah.
So there are patients who can lose a lot of weight, but most of patients will not even touch 10% despite all of this.
Right.
So after having spent so much money, because these medications are not cheap, you're not actually achieving your goals, which is to
Right.
lose more than 10%.
Right.
So with that, these are the patients who may actually want to consider bariatric surgery.
So you use this mostly as a bridge.
Yeah, as a bridge, while getting patients adapted to the. It's not like you come into the clinic one day now and to tell me, oh, yeah, I want bariatric surgery, then tomorrow we
Yeah.
send you for surgery.
Exactly.
It doesn't work that way.
Yeah.
You have to be mentally prepared. You have to, be physically fit.
Yeah.
We have to do screening tests and whatnot
Yes,
on you
yes.
first.
Yes.
So, some centers will even get a psychological evaluation
Yeah.
to make sure that you are mentally prepared, because it involves a lot of change in your lifestyle. So it's nice to just say it at your mouth, but not actually practice it. And we do have patients who fail these kinds of procedures because they don't actually comply to what is required.
Okay, that's great. So, Dr. Malik, what you're saying is, it doesn't mean that when you come and see any one of us, we straight away.
There's no guarantee that you will get the procedure.
Yeah, exactly. We won't straight away take you into OT and operate on you,
No.
basically.
Okay.
Okay. That's the message we want to put across.
Yes.
Okay, so we will do things slowly, we will prepare you for the procedure. We will determine whether you need it or not in the first place.
Correct.
And then only we will decide.
But we also need to make sure that whether you can stick with the program after
Good.
we do this.
Yes, follow up.
With the VLCD and the
Yes.
no binging and don't stretch the sleeve and that
Yeah.
kind of thing.
Yeah. So during MCO, I don't know whether you guys agree, but I find that my patients are getting bigger and bigger. I think the MCO puts a heavy strain on our patients, and Dr. Malik manages a lot of diabetes. So I don't know whether your patients with diabetes.
Basically, inactivity. You see, as part of any healthy lifestyle, you should have exercise. So we always tell patients 30 minutes per day, and it's 30 minutes per day to lose weight and 1 hour per day to maintain that weight loss. So MCO is not really an excuse, because you can walk on, you can run at home, you can do all kinds of things. Go on YouTube. There's so many exercises. So MCO should not be an excuse. And by right, you should be eating healthier because you're at home anyway. So, but unfortunately, you can cook yourself, maybe cut down on the oils instead of buying economy rice or drink stuff on Grab and all that. So there are many things that you can do. But yes, inactivity, MCO, CMCO are all excuses people give us.
Okay, Dr. Malik, we have a question. Even if you have no comorbidities, can I still undergo bariatric surgery because I want to be healthy or lose weight? Okay, let me answer this first, and maybe I'll ask Dr. Badrul to come in as well.
Sure.
So for me, patients who come to us, I think majority are in this group. That means they have heard from someone that there is a way that they can lose weight, and then they come and see me. But generally, when you ask them questions, they have got some problem related to the obesity which they have learned to live with. For example, joint pain. They find that their back pain and their knee pain or their hip pain is something normal. And then when you ask their wife, you find that the wife has got a lot of sleeping problems at night because the husband snores a lot or the patient snores a lot. And this is a problem for patients who are big size. They have what is known as sleep obstructive sleep apnea or sleep apnea in some cases, where they snore a lot and they don't have good quality of sleep and things like that. The third group of patients I find that come and see me, but they don't seem to know, is patients who have got subfertility for some time. Married couple, but no children for a long time, been going around and been told a lot of other things. But actually, weight loss and weight reduction can actually help them to actually be able to conceive again. So these are my group of patients. Dr. Badrul, what do you think?
I quite agree.
Yeah.
Usually they come and they say, look, I've been told to come, or my partner or my spouse push me to come because I'm overweight and whatnot, and but I'm fine.
Yeah.
But I think it's very, very rare for us to find the so-called healthy obese.
Yeah.
Really healthy obese, because a lot of times you see them and then I send them to Dr. Malik and somehow he'll find some pre-diabetes,
Yeah.
a little bit of elevated blood pressure. So it's very, very rare. But even then, if we truly get a healthy obese, nothing, completely nothing, no symptoms at all, nothing related to the excessive weight, if they fall into that category, a BMI of, for our level, 35, then they should be considered for bariatric surgery.
I agree.
If they genuinely want to lose weight,
Yeah.
they genuinely want to become better.
Totally agree.
Yes, then I would consider people who are so-called
Great,
healthy obese for this sort of operation.
Okay, let's see what else we have. So now let's talk about side effects. Okay, now as your body reacts to weight loss after surgery, you may experience some of the following: body aches. I don't seem to have any patients with body aches. Fatigue, you have any? I think they have more energy actually.
Correct.
more energy.
This
Feeling-
looks like a slide for hypothyroidism.
feeling cold. No, I think should be okay if they cover up at night. Hair thinning or hair loss? No lah, boss.
Well,
No lah.
too late for you and me.
Mood changes, I agree. Some of them become much happier actually.
Correct.
So and dry skin, I don't think so. So how do I put it so that we have a good take home message? Very little side effects to this procedure that you can take back. You can think of anything, Dr. Malik.
No, actually, the one that comes to mind is an American lady who we did remember from American lady who lived in Indonesia, and her insurance company in the US asked her to come here to do the surgery. So she came here.
Okay.
He did the surgery one day. Next morning she was out of hospital.
Yeah, that's normally how it is.
Yeah, so she's the one who I remember as the model for no major issues when getting operated on.
Yeah. In fact, some countries are trying to advocate this
Daycare.
They are trying to advocate daycare, but because you cannot get a standard consensus on how to do it in daycare basis, so they cannot do it. So let's talk about what do you do before and what should you do after. I'll answer maybe before.
Sure.
Dr. Badul can answer after.
After.
Okay, so what do you do before? Okay, the first thing you should do is you should, number one, you must have a need, or you must feel that you want to do the process on your own. It is not somebody who has forced you to do it, or it is not you being coerced to do it for some reason, because the one who undergoes the procedure, the transformation, the change and all is you. So the first thing is you should want to go. You should want to do it on your own. The second is, I believe that you should have done some measures to actually lose some weight on your own. Correct. So that means you should have done some dieting, proper structured dieting, some proper structured exercises before you had come. And I would suggest that before you come for surgery, it's good for you to go online in Facebook, or there are many bariatric groups now available that you can get information regarding the procedure as well. And I find that the bariatric groups are very active, and they share information very easily. Then once you've decided what you can do is look for a center that is able to give you the whole spectrum, the whole team under one roof. For example, you have a trained physician, you have trained surgeons, you have a physiotherapist, you have a dietitian, and you have a backup. Though we talk about all the good things about this surgery, sometimes things do happen and we need backup as well. So it's good to get the procedure done in a good tertiary center. Beyond that, I suggest when you come and see us, come with a positive mindset, because this will be a process that basically transforms not only your life but also those around you. Dr. Badul, what do you think about after surgery?
It's probably a continuation of what you do before. I mean, it's not a lot of patients. Well, that's why I think we spend a lot of time counseling them before the surgery. So because we need to make sure that they can stick to the program.
Yeah, definitely.
Surgery is not the. I think we should look at it as surgery to break the vicious cycle. Otherwise, you can't break this cycle of losing a bit of weight, gaining back again, losing weight, gaining back again. So surgery breaks this. But you still need to be on the very low calorie diet. They still need to do the exercise. A lot of some of these patients, because we are not informed properly or they are too happy with the weight loss after the operation, they don't do exercise. And then we find that a lot of patients who are still very exercise a lot, they lose a hell of a lot of weight. Very, very good looking. Not very, very trim, very healthy, to the point that we don't even recognize them when they come back and see us. So it needs to be maintained.
It's a lifelong commitment, basically.
Yeah, definitely. We can't have people binging again, because you will stretch the sleeve. You will stretch the stomach, and then you'll be back to what you were before.
Definitely.
And then you have to come back to us and we'll sleeve the stomach again.
Alright, another operation. We're happy to do it, but leceh lah.
Yeah.
Okay, we have a question from Aspal again. Okay, is there a side effect of low libido? Okay, so now, Dr. Malik, I think I start first lah. So I have a few patients who have come back. Across the board, I can tell you that the results can vary in terms of weight. That means some patient can lose 10 kilos, some patient can lose 50 kilos, some patient can lose 5 kilos, or 15 kilos, something like that. Some patients can actually regain back some appetite, some cannot. But I find the constant factor among all these male patients is their libido goes up. Or they can have healthier sexual relationships with their partners lah. I don't know about you lah. What do you?
No, the reason is quite clear. It's conversion of testosterone to estrogen.
Right.
So the more fat you have, the more testosterone is converted to estrogen and stored in the fat. So it slowly releases this, and that's why, if you're very overweight or obese, you have breasts, and it's called gynecomastia and so on. So when you get rid of the fat, the testosterone acts where it's supposed to act, rather than being waylaid and stored elsewhere lah. So yes, definitely.
Right. I think you have to be careful lah. Okay. Will I need to continue taking medicine for heart disease, diabetes, and other complications after bariatric surgery?
Okay, so basically, before you go for all of these, we get a proper assessment. You'll get an endoscopy, you'll get blood tests and so on. And if you're already on, if you're diabetic and so on, we will check to make sure that there are no complications. Now, a lot of times when you start hitting the 10 to 15% mark, you will start to find that your medication that you need for diabetes control is much less. There is a possibility we may stop medication, or if you are on four medications plus an injection, for example, you may end up, either stopping, or you may be on half that medication. Definitely what will happen is the medications will go down. Whether we can stop or not remains to be seen when you come for regular follow-ups and all that. But the promise is that diabetes control will be easier and better. Blood pressure control will be easier. Cholesterol, triglyceride levels will be easier to control. So generally, you will be a happier person with maybe less number of tablets, and you're more likely to live longer. So that's the promise that we tell our patients when you go for bariatric surgery.
Yeah, great. Let's see what else we have.
As surgeons, the main motivation for us to do this operation is not actually for the weight loss.
Yeah.
It's for the metabolic effect. Exactly. The main reason why we are also pushing for this.
Definitely.
It's because, we have a chance to improve diabetes, hypertension.
You're right. It's the medical aspect of it.
Correct.
Okay, after my stomach size is reduced, am I still able to carry out fasting or diets as before? So I would think that it is much easier actually.
No, you should be carrying out all this lah.
You should be, and also it's much easier for you to do it lah, because you don't have any more ghrelin in your system, and
correct,
your GLP-1 goes up. So I think it's much easier actually for you to carry it on. So basically we are giving you a jump start lah, to not only lose but also to alter your programming to lose more weight in the future lah. So can I still get pregnant after bariatric surgery? How will this affect future pregnancies?
More likely to be able to get pregnant. Yes. So infertility, polycystic ovaries.
Correct.
In fact, with women, you find that the testosterone levels may go down and you become more fertile.
Correct.
So there is,
So, but I think, Dr. Malik, we have to stress that after they undergo the procedure, we encourage them not to get pregnant for at least 18 months lah. The reason is because the body is still losing weight, and there are some regulations in hormone and all, that it is safer for them to get pregnant after 18 months. So what do you do, Dr. Malik, if you want to have sexual intercourse during that time? How do you manage it?
Basically, okay, the few things that we warn patients. One, fertility rates go up, so you have to be careful. So, I mean, I'm sure I don't have to teach you about contraception. So, there are various ways of actually not getting pregnant. So, you may want to practice one or two of those methods, lah.
Okay.
Either withdrawal or use an oral contraceptive pill or use a condom or whatever it is.
Okay.
Because the risk of pregnancy definitely will go up.
Correct.
When you do this procedure.
So generally, the risk of the chances rate of pregnancy becomes better,
higher.
higher. However, when we do the surgery in a patient who's in a childbearing age, we tell them, as far as possible, for 18 months, you
Try and avoid
try to avoid it. But beyond that, I think it's quite safe. What about patients, Dr. Badrul, who have had previous pregnancies, cesarean sections, for example, operations? Is the surgery safe for them?
Oh yeah, I don't think there's an issue.
Yeah. I don't think there's any issue. So patients feel that when they come and see me, they say, "Oi, doktor, saya sudah kena belah dekat bawah tau. Boleh buat ni operation ke?" I think it's okay, because it's totally different. Atas and bawah different, isn't it?
Sometimes you get people who have developed a hernia from
Correct.
previous operation. So we end up doing that as well as a bariatric operation. So there you go.
I'm glad you brought that up, Badrul. So now you see, patients who are obese generally also
they do.
tend to have hernias. Hernia untuk orang yang people who is actually angin pasang or hernia lah, bonjol lah dekat bawah sini or perut. So basically we can do both the procedures in one sitting.
Correct.
That means we can reduce weight and we can fix the hernia. And generally, the outcome of the hernia also is much better after that.
Don't forget, you remove gallstones as well.
Remove gallstone. Okay, isn't bariatric surgery considered cheating or taking a shortcut compared to exercising and losing weight naturally? I don't think it's cheating.
I don't think it's cheating because you can, as we said, it's only 5 to 10% chance.
I don't think it's cheating. I don't think it's cheating. I think this that's why I don't know lah. I mean, you guys must have seen. I mean, I had very close friends who, whenever I talk about weight loss, they will always paint a picture that the patient is at fault when they have gained weight, and that the patient is someone who refuses to alter their life to lose weight. But actually, I think it is way beyond just consumption and output. It is, something that the patient is born. I mean, is ingrained with. There is some genetic factor as well. And so to say to the patient that you are cheating by going for bariatric surgery, I don't think it's fair.
Well, I understand where this is coming from.
Yeah.
Because, whenever we've done our patients, we've done the weight reduction and all that, for all this. And then we said, why don't you just, come on and explain to our patients a little bit about bariatric surgery, and a lot of them are actually reluctant.
Shy.
Because I think the main issue is that nobody regards obesity as a disease. As
Correct. Correct.
It's considered a
Lifestyle.
failing
Correct.
or
Correct.
loss of self-control or whatever it is. But it should be considered as a disease.
Yeah.
And we are trying to treat a disease. We're not trying to do cosmetic operation.
Actually, WHO has considered obesity as a chronic disease now. So
Yeah.
it fulfills all the criteria of a chronic disease.
Yeah.
So it's not about beauty anymore. It's about trying to make things better metabolically so that you can live a longer and healthier life.
Yeah, you're right. You're absolutely right. So actually, video. Okay, so let's go back. So actually, Dr. Malik, in that case, why? I mean, we want to let everyone know very clearly that not only do patients perceive it as a cosmetic procedure, even insurers look at it as a cosmetic procedure, and it is not insured at the moment. We are fighting very hard to get it insured. The reason why we feel that it should be an insured procedure is because when you perform this procedure for patients, you avoid coughing out a lot of money and effort later in the future to support other things like hypertension and diabetes and things like that. So, Dr. Malik, with all these benefits, and Dr. Badrul, why do you think the insurers are not coming into play? Why? What is the problem, you think?
What we find is that it depends on who your insurer is. So if we have foreign patients, which, I mean, obviously we do, a lot of the American insurance companies
They
accept
cover.
this as a means of treating a problem.
Yeah, yeah.
So they will cover.
Yeah.
Our local insurance companies, again, consider anything that's obesity related is often considered to be a lifestyle thing. It's about beautification, which I think is a wrong concept, lah.
Yeah.
So until they learn, the insurance companies are actually going to end up paying a lot more in the longer run.
Yeah.
I suppose they have to learn the painful way, lah.
Yeah. Yeah.
Well, we have had one or two successes.
We've
The
had-
very odd and rare one
Right.
that
Where the insurers pay.
as a metabolic problem.
Yeah. Yeah. I also have had
Yeah,
a few.
yeah. So
So as a metabolic problem,
Right,
yes,
right,
some
right.
insurers will consider.
Right.
But I think we've made some headway because EPF allows withdrawal.
Correct.
So there you go.
Right. Right. I was very happy to
Yeah, for
be
your
part
effort.
of that group.
Yes. EPF allows
EPF.
withdrawal for us to
Yeah,
for
yeah.
you to undergo.
I think for all of you listening out there, support the bid to have insurance for obesity surgery. You can do a hashtag insurance for bariatric, insurance for obesity. So I think Dr. Badrul will run through a video now.
Yes, it's
And,
a very short one just to
let's
round
have
things
a
up.
look.
This is a sleeve gastrectomy. Okay. Just a very brief video just to show you what are the key steps, because I've had some inquiries about how you actually do this operation.
So this is
So
the stomach,
immediately-
Dr. Badrul, huh?
Yep, the stomach,
Okay.
and you see the liver is full of fat.
Right.
So we start off with just making a little mark on the stomach to where before we start where we are about to start stapling the stomach. But first of all, we release the fat from at the greater curve of the stomach. Then we start the stapling. You got this wonderful device that can cut it and staple it. So there you go. So just keep doing this all the way up, and then I tend to stitch the whole thing to make sure it doesn't bleed, stays very dry, and also another layer of protection. And that's it. You just check, make sure nothing is leaking, and of course, don't forget to take out that bit that we've removed, the little pouch. So there you go.
So it looks very simple, but actually no, Dr. Badrul, it requires everyone can do it. So it's actually
I can see Dr. Malik is very tempted now.
yeah, no,
Doesn't look too bad.
can do it myself.
So I think we've come to the end of our session, and I think it was a very good discussion. And please, if you, I think I have some. I think each of us will just say some final parting words.
Yep.
Do you have any questions from this
No
one?
more.
No more. Okay, so I think I start Dr. Badrul first. Do you have any?
We wish this thing would be, if you look at the numbers, if you look at the people who are really in need of this, and we know from worldwide statistics that the people who actually need this, only 1% or less actually get this. So there's lots of people even in Malaysia who needs this. So we really wish that this thing would take off.
Yeah.
But don't look at it as an operation shortcut or whatever it is. Look at it as a very effective way of treating or preempting a lot of problems in the future.
Yeah, I agree.
It really is.
So yeah, I mean,
Dr. Malik?
basically, you're preventing a lot of pain later on.